For that, I invite Dr. Narasimhan, Associate Professor, Department of Anesthesiology from Stanley Medical College, Chennai. I invite Sir to talk about interscalene brachial plexus block and superficial cervical plexus block. Sir, over to you.
I'd like to thank the organizers of Preeti Anesthesia Update for giving me this excellent opportunity. In particular, to Dr. Balaji and Dr. Suresh for giving me this opportunity. In the next 20 minutes or so, I'll be discussing about interscalene brachial plexus block and superficial cervical plexus block. So as we all know, upper limb nerve blocks are the most frequently performed peripheral nerve blocks by anesthesiologists. Interscalene block, it is indicated for analgesia involving the shoulder and proximal humerus. I bring warm greetings from my workplace, which is the iconic Stanley Medical College. So as Dr. Gurumurthy sir was discussing, we all know brachial plexus, it starts from root level and it goes to the terminal branches. So brachial plexus starts from ventral ramus of C5 to T1 nerve roots. That is the root level. C5 and C6 join to form the upper trunk. C7 forms the middle trunk. C8 and T1 forms the lower trunk. So in interscalene block, we'll be doing blocks at the root level. Whereas with supraclavicular block, supraclavicular brachial plexus block, we do block at the level of trunks and divisions. Whereas when I come to infraclavicular block, so we have medial costoclavicular block and lateral infraclavicular block. Here we do block in relation to the first part of axillary artery, whereas here we do the block in relation to the third part of axillary artery. And finally, at the axillary brachial plexus block, we do block of the terminal branches of the brachial plexus. The 5 branches, main branches are musculocutaneous, axillary, median, radial, and the ulnar. I want you to remember this very important point, the dermatome level of interscalene and supraclavicular block. As you can see there, this is by the intercostobrachial nerve. It almost covers the entire upper limb. Whereas your interscalene block, it gives coverage over the cape of the shoulder, extending to the neck. So interscalene block, I will do when there is, I need shoulder and also for the upper humerus surgeries. So it all started by Vinny. This was a landmark paper in 1970 where he identified this interscalene groove. So we are all people who started with landmark guidance. So we all are very interested in palpating this interscalene groove, which is of historical interest now with the advent of ultrasound. So what we normally do, we identify what is called as bunch of grapes and stoplight sign. So we all know this is the first rib, subclavian artery, hypoechoic nodules which are lateral to the subclavian artery. These are the brachial plexus elements. So as I trace back, I see the brachial plexus getting arranged vertically between the 2 scalene muscles. We commonly call it stoplight sign. So a few years back, I'm happy to say this. I'm happy to see these brachial plexus elements, I do the block. Is it right? As Gurumurthy sir was pointing out, we need to understand that variations in brachial plexus can be up to 30%. So if we don't correctly identify the individual elements of brachial plexus, the chances of block failure are extremely high. So in the next 15 minutes or so, I'll be discussing about how to decode what is this stoplight. And probably Dr. Sandil Kumar Mohan and Dr. Ganesan sir will be discussing this bunch of grapes. So this is what we are interested. Right? We have the anterior scalene muscle and we have the middle scalene muscle. This is the interscalene groove or interscalene gap or interscalene space. And this groove is introduced by this interscalene groove is introduced by Dr. Vinny. We all know C5 to C8 elements are arranged between these 2 scalene muscles. And I want you to see this subclavian artery. The relationship of the brachial plexus is cranio-posterior and lateral. So when we see the subclavian artery, when we trace above, we'll be able to see the interscalene groove. So that is the trace back technique. And another very important thing is they show the phrenic nerve here. Phrenic nerve, it is in very close relationship to interscalene groove. And another important landmark is the vertebral artery. which comes from the first part of subclavian artery, it goes into the foramen transversorium of C6. So the chances are that when you are injecting in relation to this, you might accidentally enter into the vertebral artery, which is a catastrophic event. And another important landmark I have shown here is the suprascapular nerve. Why it is important? It is responsible for 70% of sensory innervation of shoulder. So this is of very importance to anesthesiologists. So let us start with a bit of cadaveric anatomy. So this is done in our Stanley Medical College. So as we reflect the skin, we are seeing the cadaveric dissection on the right side of the neck. So what we see is the superficial fascia, which contains the platysma muscle. So immediately beneath the skin, we have the platysma muscle with the superficial fascia. As we reflect that, we have the investing layer of deep cervical fascia, which stretches between two muscles, sternocleidomastoid and trapezius. So as you can see here, second layer is the investing layer of deep cervical fascia, which extends between the sternocleidomastoid and trapezius muscle. And next layer will be the strap muscles. We have 4 strap muscles. They are arranged in 2 layers. We have the omohyoid, sternohyoid, sternothyroid, and thyrohyoid. So these are the 4 strap muscles which are in the midline on either side. So he is showing the omohyoid muscle. It has got a superior and an inferior belly of omohyoid. So coming to the fascias of the neck, 2 fascias are extremely important for anesthesiologists. The one which is marked in maroon is the investing layer of deep cervical fascia. As we see here, it invests the sternocleidomastoid, it goes posteriorly, it invests the trapezius muscle. So this is the investing layer of deep cervical fascia. Next important fascia, which is marked in orange color, is the prevertebral fascia. This encircles the scalene muscles. So when I wanted to do an interscalene block, my needle has to pass beneath the prevertebral fascia between the 2 scalene muscles. And another important point to be noted here is, so we have the vagus nerve here, we have the phrenic nerve here, we have the recurrent laryngeal nerve over here. So when the injection is given in the wrong planes, the injection can track to these areas. It can cause Horner's syndrome, it can cause hoarseness of the voice, it can even spread into the neuraxial space. So very important to remember this prevertebral fascia and the investing layer of deep cervical fascia. So continuing our cadaveric dissection, now the cadaver position is like this. So we are seeing the right side of the neck. So this is for orientation. So as we see, we have the midline and they are reflecting the sternocleidomastoid. We see the omohyoid muscle. It has got a superior belly and an inferior belly of omohyoid. So the internal jugular vein, because of embalming, it is abnormally thicker in size. We have the carotid artery here, and in between the carotid artery and the IJV, we have the vagus nerve. So our area of interest is the posterior triangle, which is behind the sternocleidomastoid. So we are seeing the scalene muscles. We have middle scalene and the anterior scalene muscle, and what we see is the prevertebral fascia. So this is very important. The drug deposition has to be under the prevertebral fascia. This will be covering this posterior triangle. So it is reflected to see the brachial plexus components. So this is the prevertebral fascia, what he is holding. Now we can see nicely the anterior scalene muscle and the middle scalene muscle. So we have the transverse cervical artery, which arises from the thyrocervical trunk, which in turn arises from the subclavian artery. So it's a highly vascular area. This has to be remembered. So of the brachial plexus, the small root is the C5, C6, they join to form the upper trunk. We have C7, C8, and T1 is a bit difficult to visualize. As you can see there, this is the T1 nerve root. So the smaller one, the small root C5 and C6, they join to form the upper trunk, and from the upper trunk you have a small nerve which is the nerve to subclavius. So I is showing the upper trunk there, and from the upper trunk we have the posterior division, anterior division, and the suprascapular nerve. So this is the Ebb's point where 6 nerves meet. So what he is showing is the suprascapular nerve, which is in close relationship to inferior belly of omohyoid. We use this while doing the anterior suprascapular nerve block. So then we have the posterior division and anterior division. So this is described as the spa arrangement of brachial plexus. So this is the spa arrangement of brachial plexus. So in the ultrasound, we are going to see all these components. And another nerve which is of importance to anesthesiologists while doing interscalene block is the phrenic nerve. As you can see there, it runs on the surface of the anterior scalene muscle. It runs in a lateral to medial direction. So that is how you identify the phrenic nerve. And this is the vagus nerve. So when you do deeper dissection, when you dissect the carotid sheet posteriorly, we are able to see the cervical sympathetic trunk. So this is the vertebral artery which arises from the first part of the subclavian artery. It goes into the transverse process of C6. So while doing interscalene block, so we not only face the nerves, but we have many vessels which come into the role. We have the common carotid, subclavian artery, vertebral artery, transverse cervical, dorsal scapular artery, and not only that, we have the phrenic nerve, cervical sympathetic trunk, and the recurrent laryngeal nerve. So all these things lead to the complications which we were discussing yesterday. So what is more important is to understand anatomy and correlate with sonoanatomy so that when you do the block, we can avoid the complications. Now coming to the sonoanatomy of interscalene brachial plexus block. So we're going to start the scanning from the midline. From the midline, we're going to scan laterally and see what important structures we're going to see. So this has been dealt with by previous speaker. So in the midline, we have the thyroid cartilage. And as we move laterally, we see the strap muscles. So moving from the midline, laterally, we see the two layers of strap muscles over here. And as I move still more lateral, this is the carotid artery, internal jugular vein, and the sternocleidomastoid. So we all know posterior to sternocleidomastoid is our area of interest. So as I move laterally, I have the anterior scalene muscle coming into view, and then I have the middle scalene muscle. So I have the brachial plexus elements arranged in the interscalene groove. Now, how to identify these individual components of the brachial plexus? So this is a very important slide. So we all know C5, C6, C7, they have, C4, C5 and C6, they have both anterior as well as posterior tubercle. Whereas when you look at C7, the anterior tubercle is absent or rudimentary, whereas it has only a posterior tubercle. So when you look at ultrasound, when you have a posterior tubercle alone, it is the C7 transverse process. Whereas when you see the C6 transverse process, it will be having two tubercles, anterior and posterior tubercle. So with this unique sonomorphology, we'll be able to identify which is the C7 nerve root and which is the C6 nerve root. So when you see a posterior tubercle alone and a nerve root, it is the C7 nerve root. When you see anterior and posterior tubercles with a prominent anterior or Chassaignas tubercle, it is C6 transverse process. Whereas C5 will be having anterior and posterior tubercles. So this is how you differentiate C5, C6 and C7. So we'll start by identifying the C7 and then scan above. So we'll start from where we left. So as you can see here, we see a posterior tubercle and a nerve root. So this is probably the C7 nerve root because the transverse process is a posterior tubercle. Tubercle is either absent or rudimentary, as you can see here. And another very important thing is it is in close relationship to vertebral artery. Accidental injection will result in seizures. So as I track above, you see the C6 nerve root. This is the C6 nerve root. So we have the C6 transverse process which has an anterior and posterior tubercle. It is giving rise to the C6 ventral ramus. So this is the C6 ventral ramus, and as we trace still above, so I'm moving the probe cephalad, we can see the C5 ventral ramus going into the C5 transverse process. So this is how we identify the individual elements of the brachial plexus. This has a two bifid transverse process. So once again, we are moving caudally. We could see the C5 nerve root coming out and then the C6 nerve root coming out. So keep track of this C5 and C6 nerve root. They both join and forms the upper trunk. Whereas we have the C7 nerve root emerging out of the C7 transverse process. So we have now the interscalene groove nicely formed by C5 bifid C6 and C7 ventral ramus. So this is the point where we classically do the interscalene block. So as I trace further down, we have the C5, C6, C7 and C8 ventral ramus. It is nicely sitting on the first strip T1 transverse process complex. So when you trace still further down, we have the T1 nerve root emerges from under the first strip and it will come and join with the C8. As you can see there, it joins with the C8 to form the inferior trunk. So we now know that what is the stoplight and what is the bunch of grapes and how to do injections while you do an interscalene block. There are two types of injections. We have what is called as a periplexus injection and intraplexus injection. So periplexus injection happens between the scalene muscle and the brachial plexus elements. The needle will be staying just lateral to the brachial plexus sheet. In the intraplexus injection, the needle will be placed between the C5 and C6 nerve roots. It has been proposed that when you do an intraplexus injection, there are chances of intraneural injection. So coming to how the block is performed. So we have the C5 root here, the C6 root here. When you move the needle, it is always advisable to move in the space between these two nerves because it's a thick fascia. When you target the nerve, you might accidentally injure the nerve. So as I advance, I could see a distant pop. So as I inject local anesthetic, so it's spreading somewhat laterally. So I'm not happy with this. So I make small needle adjustments. So always movement should happen between the two nerve roots. And once I am happy with the position, I give another small aliquot. It is nicely spreading, outlining the C5 and C6 nerve roots. So we have the C7 nerve root here. So as I give 5 to 7 ml of local anesthetic, it nicely spreads around the C5 and C6 nerve roots. So most important is we need to scan to see how the drug has spread. So you can see that the C6 is becoming bifid here. So as I scan, you see that the drug has nicely spread around and the three components of the upper trunk, that is suprascapular, posterior and anterior division are nicely seen. So this is a good injection. So coming to another another needling case. So we have the interscalene groove, anterior and middle scalene muscles. So needling is done in plane from lateral to medial. So I'm trying to open up the space between the middle scalene muscle and the brachial plexus components. So this is a periplexus injection. And once you move the needle between C5 and C6, this becomes an intraplexus injection, which carries the risk of inadvertent neural injury. So another very important thing to be remembered is when you do in-plane needling, your dorsal scapular nerve might come into role. As you see here, this is the dorsal scapular nerve. The needle is being advanced. So what we have done is we used a nerve stimulator trying to stimulate this dorsal scapular nerve at a current of around 0.9 to 1. Let us see what twitch we are getting when we stimulate the dorsal scapular nerve. Can you appreciate the twitching of the levator scapulae and rhomboids muscle? So this means that when you do a in-plane needling, without taking into account, you might injure the dorsal scapular nerve and the long thoracic nerve. So some anesthesiologists advocate out-of-plane approach to the interscalene groove. So when doing in-plane needling, while traveling to middle scalene muscle, be aware of dorsal scapular nerve and long thoracic nerve. So finally, how to identify the phrenic nerve with ultrasound. So as you can see there, we have the C5, C6, C7 nerve roots. So focus on this component, right? This component as I trace above. So this is the C7. While I go to the C6 level and C5 level, this is coming closer to the brachial plexus, right? So I'm going at the C5 level. You can see that it is in very, very close relationship to the C5 nerve root. So as I trace down, right, this is the phrenic nerve. C6 appears. This moves a bit lateral, or sorry, medial. And as I trace the C7, it is moving still further away. So, when I come to C8 level, it has gone still further. So, what is the implication of this? As we all know, interscalene block, it leads to decreased or absent movement of the diaphragm. So what the advocates of superior trunk block suggest is, when I do a block at the C5 level, the phrenic nerve is too close. So instead of doing an interscalene block, you move the probe corded, so that the distance between the phrenic nerve and the ultrasound probe increases, so there is decreased chances of involvement of phrenic nerve. So this is about superior trunk block. So this we have discussed before. So with superior trunk block, the probe moves down, the distance between the brachial plexus and the phrenic nerve increases, so that there is decreased chance of involvement of phrenic nerve. So there are other diaphragm sparing nerve blocks as well. We have a selective suprascapular and selective axillary nerve block. We can combine an infraclavicular block with a selective suprascapular nerve blocks. So as we have discussed before, this is a highly vascular area. So we have transverse cervical artery, subclavian artery, dorsal scapular artery, and all these arteries, they will be there. The most important point is nerves above the clavicle are hypoechoic. These blood vessels are also hypoechoic. So before you inject local anesthetic, put color Doppler, make sure that it is not, because vertebral artery, it is directly communicates into the brain. As Ganesan sir was pointing out, even 2 ml of local anesthetic, it will cause seizures. So during my postgraduate days, every week in Madras Medical College, we used to have a case of seizures while doing interscalene block. So be aware of this, very, very important complication. Always put a color Doppler, rule out it is not a vessel before you proceed with the block. So complications of interscalene block, this is what we have been discussing. You see, there is a long list. It's not that you should not do this block. Take adequate precautions, understand the anatomy and sonoanatomy, so that you decrease the complications. As we are discussing before, this is our area of interest. When you accidentally go inside, it becomes a neuraxial spread. When my drug tracks in front of the scalene muscle, I involve the phrenic nerve. When my drug goes in this plane, it goes and acts on the vagus nerve. It might act on the cervical sympathetic trunk. Still more dosage, it can act on the recurrent laryngeal nerve. So all these complications, Horner's syndrome, recurrent laryngeal nerve palsy, diaphragmatic palsy, can all happen when we use increased volume and not exactly knowing the anatomy. So proper anatomy and proper precautions will decrease these complications. And coming to the superficial cervical plexus block, we all know that at the Erb's point, these nerves, the superficial cervical plexus comes out. Of importance to anesthetists is the supraclavicular nerves. They supply the clavicle and the cape of the shoulder. We have the transverse cervical nerve, great auricular, and the suprascapular nerve. So let us see. So what are the injections we do here? So we have a superficial approach to cervical plexus block. We have an intermediate cervical plexus block. Then there is the deep cervical plexus block. So this is the sternocleidomastoid, which is covered by the investing layer of deep cervical fascia. So the blue one is the investing layer of deep cervical fascia. The green fascia is the prevertebral fascia, covers the scalene muscle. So when my injection happens superficial to the investing layer of deep cervical fascia, it becomes the superficial approach to cervical plexus block. Whereas with intermediate injection, which we commonly use, the drug deposition happens between the investing layer of deep cervical fascia and the prevertebral fascia. Whereas deep cervical plexus block, the injection happens beneath the prevertebral fascia. It has a lot of complications, so it's not commonly practiced. So this is my last slide. So let us see how a superficial cervical plexus block by intermediate approach is being done. So this is the probe position at the midpoint between the clavicle and the mastoid process. So what we see is the sternocleidomastoid muscle. The needle is being advanced. This is very superficial. So we need to be careful about that. So I'm trying to come just beneath the sternomastoid, which is covered by the investing layer of deep cervical fascia. So as I give 2 to 3 ml, you can see there the space between the investing layer and the prevertebral fascia opens up. So this is the scalene muscle which is covered by the prevertebral fascia, and this is the investing layer of deep cervical fascia. So about 3 to 5 ml of local anesthetic, it is injected between this to block the superficial cervical plexus. So this is the intermediate approach to superficial cervical plexus. So I thank all of you for a very, very patient listening. Once again, I thank the organizers for giving me this opportunity yet again. Thank you.
Sir, thank you, sir. Sir, I have two questions, sir. Sir, first one is incidence of phrenic nerve block in superficial cervical plexus. Which one is better, sir? Going for a superficial or intermediate technique? Which one is safer?
Actually, prevertebral fascia is a very thick fascia. So the chances of phrenic nerve will be very high when you breach the prevertebral fascia. Of late, I am in surgical oncology posting where I see daily functional neck dissections. So prevertebral fascia, it's a very, very tough fascia. That is why when you push the advanced needle, you will have a resistance while passing through the prevertebral fascia. So in the pre-ultrasound era, the what shall I say, click, they say, facial click, it is based on this prevertebral fascia. So when you are above the prevertebral fascia, the chances of phrenic nerve palsy are almost nil. But in case you are not able to identify correctly the prevertebral fascia and you go beneath that, there might be a phrenic nerve palsy. Superficial cervical plexus block, there is no chance because you inject in the subcutaneous tissue above the middle scalene muscle. So I think it is absolutely safe. Even with intermediate cervical plexus block, if you do it correctly, the chances are almost nil.
Sir, volume recommended, sir, for
Volume for?
superficial cervical plexus.
I use 3 to 5 ml, but in books they say 2 to 3 ml is sufficient.
Yes, sir. Another question is during interscalene block, what you have shown is the drug is spreading mostly on the lateral side. Is it enough, sir? Or we need to have a circumferential or medial
No,
spread?
there is no need to go for a circumferential spread. The injection has to happen between the middle scalene muscle and the brachial plexus components, because when you go and inject on the other side, you might involve the phrenic nerve, which is on the surface of the anterior scalene muscle.
Thank you, sir. Thank you, sir.
Thank you.